Our next speaker is Dr. Tristan Clark, who is a consultant physician and an associate professor in adult infectious diseases in Southampton, UK. So he's traveled a long ways to be with us today. And he is making a career specializing in influenza, particularly diagnostics and rapid molecular diagnostics. So this is an area in which he knows quite a bit. And he's going to talk to us today about routine molecular point of care testing for respiratory viruses in adults presenting at his hospital. So please welcome Dr. Clark.
Thank you, Wade. Can everyone hear me? Excellent, excellent. So I'd just like to thank BioFire for asking me to come and talk to you today about my trial. Just check that this works. Okay, so first of all, this is my conflict of interest statement. Okay, so I probably don't need to explain to an ID audience about the importance of respiratory viruses as a cause of acute respiratory illness in adults presenting to hospital. But just to remind you that modern studies using molecular techniques, when you test everyone who comes in with acute respiratory illness, you can find a respiratory virus in about 40 to 50% of adults. Okay, but despite how common respiratory viruses are in this patient group, our approach to testing for them isn't particularly clever at the moment. And this is because in most places, testing for respiratory viruses, even during influenza season, is not done routinely. It's done based on clinician suspicion. And this is despite the fact that we know that physician-diagnosed influenza is highly insensitive, even during periods of peak influenza transmission. So you can see that the sensitivity of physician-diagnosed influenza in most studies is less than 50%, so worse than flipping a coin. And so if you imagine that this is the current approach to respiratory viral testing in hospitals, there are two major flaws to my mind with the way that we do it. The first is that viral testing is based on clinical suspicion rather than performed routinely. And as I said, this means that because we can't tell clinically who's got what, we're going to miss diagnoses. And so every year this leads to undiagnosed cases of influenza and nosocomial outbreaks that are often associated with high levels of morbidity and mortality. It also means that patients with undiagnosed flu don't have the opportunity to benefit from antiviral treatment. The second big problem with the way that we approach respiratory viral diagnostics is that laboratory PCR, which is the standard way that we diagnose these tests, takes 24 to 48 hours in most places to generate a result to physicians. And this means you cannot use those results to direct your antibiotics, your antivirals, or to make decisions about side room use. You have to make those decisions empirically, that is to say, presumptively. And then when you get those results back, you find out that you were wrong and you have to change what we do. And so this invariably drives the overuse of antibiotics and subsequently antimicrobial resistance. And it means that patients without influenza get influenza drugs, and patients who don't need to be isolated get isolated for a period of time. And so if you imagine that this is the current diagnostic pathway for respiratory viruses, if you wanted to intervene to make things better, there are 2 points where you could do that. So you could test everybody, and that way you get rid of your misdiagnoses, so routine testing. And you could replace your laboratory PCR test with a much quicker test, performed at the point of care, and that way you could use those results to direct your use of antibiotics, antivirals, and side room isolation. But of course, point of care testing for respiratory viruses, at least for flu, has been around for a long time in the form of these antigen-based tests, and many of you may have used these, may still use these. The problem with these is that in adults at least, they're too insensitive to be used as a rule-out test for influenza, and that really limits their usefulness in hospitals, and that's one of the reasons why I don't think they've ever taken off in the UK. We also did this randomised control trial a few years ago and health economic evaluation, and showed that there was actually no clinical impact of using them and that they weren't cost effective. So our recommendation was that they shouldn't be used. So that was that. But since that time, really, there's been a technological revolution in the development of these rapid molecular diagnostic platforms for respiratory viruses. And this is just a selection of the available platforms on this side, but they all share some common features. Probably the most important is that their diagnostic accuracy, by and large, is close to that of laboratory PCR or equivalent in some cases. They're also quick. So some of these are as quick as 20 minutes. They're simple to use, and some of them are in fact clear wavered. And some are comprehensive. That is to say, they test for the same panel of respiratory viruses that you would get through your centralized laboratory PCR service. So maybe these are deployable as point-of-care tests. And so this is a tagline from one of those, from the manufacturers of one of those panels. They say, knowing now matters. And my response to that is, yeah, probably it does, but you need to prove that it does. And there was no high-quality evidence for improved clinical outcomes above what we currently do, or for cost effectiveness for any of these platforms. And by that, I'm talking about randomized control trials. And so we did the RESPOC trial. So this was a single-center, pragmatic randomized control trial that took place in a large teaching hospital in the south of England over 2 winter seasons. So patients presenting to hospital with acute respiratory illness were randomized 1-to-1 to receive either point-of-care testing using the respiratory panel on the film array, and this test for a comprehensive range of respiratory viruses, or routine clinical care. And so if they were randomized to point-of-care testing, they had a nose and throat swab taken that was immediately tested on the film array, and the results were given to the clinical team and to the infection control team, and that's it. We backed off. This was just about giving information to the team. There was no management suggestions, and there was no algorithm. If they were randomized to routine clinical care, then testing for respiratory viruses was at the discretion of the clinical team, and where performed was with laboratory PCR testing. So the sample size was 720 patients, and the primary outcome measure was chosen as the proportion of patients receiving an antibiotic, and that's a list of the secondary outcomes, so including length of stay, influenza antiviral use, isolation facility use, and of course, safety. This is the trial profile, showing there's about 360 patients in each arm. I haven't shown it here in the interest of time and space, but the baseline characteristics of both groups were well matched. And so in terms of the testing, so in the point-of-care group, 100% of patients were tested for respiratory viruses. No surprise there, that was the point of the study, routine testing. And in the routine clinical care group, just under half, just under 50% of patients were tested for respiratory viruses. And this is the turnaround time in the 2 different arms. So turnaround time is defined as the time between when a decision was made to test a patient to the results being available to the clinical team. So 1.6 hours in the point-of-care group versus 30 hours in the routine clinical care group. And this is probably quite typical of turnaround times in the UK. And so testing everybody for viruses means that 45% of patients were positive for respiratory virus in the point-of-care group versus 15% in the control group. So you detect a lot more viruses, as you'd expect, and that includes influenza as well. So you can see that there's about a 40% increase in the proportion of patients testing positive for influenza with the routine testing. In terms of the primary outcome, so there was no difference in the proportion of patients who were treated with antibiotics between the 2 groups. And I guess this is, in retrospect, this was a problematic primary outcome measure, because due to the process of care in hospital, patients are of course started on antibiotics very early in their patient journey, and the time that you have to intervene in that is very, very narrow. And so what often happened was patients were started on antibiotics before the results of their point-of-care testing were available. So we did go on and do a post hoc analysis, which is shown down here. And this is just looking at the patients who weren't on antibiotics by the time their point-of-care tests were available. And this shows that in that subgroup that there was a 14% reduction in the proportion of patients treated with antibiotics, with a number needed to test of 8 to prevent 1 course of antibiotics. So we also did pre-specified subgroup analysis, as you wouldn't expect patients with pneumonia and patients with asthma and COPD to be treated the same, even if they have the same virus isolated on their test. So this is the pooled subgroup analysis of patients with exacerbation of asthma and COPD, and you can see that in this group there's a reduction in antibiotic duration of 2 days, although overall the proportion of patients receiving antibiotics was no different between the two. And you can see that the reason you get a reduction in the duration is that there's many more patients having either single doses only or very brief courses of antibiotics in the point of care group. So these patients are having their antibiotics stopped prematurely. Looking at this in a different way, so if you look at the results according to whether your test was positive or negative, so you can see that if your point of care test is negative for viruses, your antibiotic use is pretty much identical to that in the control group. Whereas if you're positive for a respiratory virus, you have this group of patients here who have their antibiotics stopped early. So going back to the intention to treat analysis, so this is length of stay, and it shows that the length of stay was about a day lower in the point of care testing group. And again, if you break this down by point of care test result, you see that if your point of care test is negative, the length of stay is very similar to the control group, whereas if you're positive for a respiratory virus, there's this group here that seem to have premature discharge from hospital. Okay, moving on to the neuraminidase inhibitor use, and in the UK this is almost essentially entirely oseltamivir use, so really we're talking about oseltamivir use. You can see that overall there was no statistically significant difference between the group in the proportions that were treated with oseltamivir, but what was different was whether they had flu or not. So in the point of care group, 82% of patients who received oseltamivir had confirmed influenza, versus just under half in the control group. And this is because in the point of care group, oseltamivir is being used in a directed way. In other words, you have a positive test for flu and you get oseltamivir, whereas in the control group, oseltamivir is being used empirically based on clinical suspicion, and half the time you're wrong, and the test comes back showing that you don't have flu, and then your Tamiflu gets stopped. And so on a similar note, the duration of oseltamivir in those who ultimately tested negative for influenza is a lot shorter in the point of care group. So this is the median number of doses. So if you had oseltamivir and didn't have flu in the point of care group, you had a median duration of a single dose versus 5 doses in the control group, which equates to between 2 and 3 days, as oseltamivir is given twice a day. And this is really a function of the turnaround time of laboratory PCR. So looking at this in a different way, so our national guidelines suggest that all hospitalised adults with influenza should be treated with oseltamivir. And so 91% of patients who were positive for flu in the point of care test group received oseltamivir versus 65% in the control group. And then those of you that work in acute areas will recognise this. I'm sure that there's some patients who have uncomplicated influenza and are hospitalised really because of diagnostic uncertainty, and knowing that they have influenza gives people the reassurance that their tachycardia and their fever is explained and they can be directly discharged. And so you can see there's small numbers of patients who were discharged directly from the emergency department with their flu result in the point of care group, but nobody in the control group. But these are small numbers, and I point out that this isn't statistically significant. Okay, so moving on to isolation facility use. So what we're talking about is side room use in the UK. Side room use is, of course, a limited resource, and we have to choose who to isolate. So I point out that the ends are different on here because we only had side room isolation data for the second year of the study. Overall, there's no statistically significant difference between the groups in the proportion isolated. But again, what is different is whether those patients had confirmed influenza or not. So many more patients had confirmed influenza in the point of care group versus the control group. And similarly, the time to isolation or de-isolation was a lot quicker in the point of care group versus the routine clinical care group. So looking at the safety, so there was no difference in total adverse events between the groups, and no difference in admission to ITU, HDU, 30-day or in-hospital mortality, representation to hospital or readmission to hospital between the groups. And so, in conclusion, a routine molecular point-of-care testing strategy for respiratory viruses in adults with acute respiratory illness leads to a reduced turnaround time and an improved detection rate for viruses, and that is associated with a higher proportion of patients receiving brief courses of antibiotics and a reduced length of stay. It's also associated with improvement in the use of directed antivirals for influenza and an improvement in hospital isolation facility use, and it appears to be safe. So this has now been published in the Lancet Respiratory Medicine, and please do go online and have a look at it. There's obviously a lot more data in this paper than I've been able to present to you today. I think the guys from BioFire have got laminated copies if you're interested. And these are my acknowledgements. Thank you very much for listening.